Hi, Dr. Kurzrock. It's great to have you back with us. So today, what we're going to do is we are going to record an interview about precision medicine, and this is for the new precision medicine module in PALTOWN University. We are very honored to have you as as a person to interview here, especially because you've been a giant in the field of precision medicine. Could you tell us a little bit about your life's work in this field?
Yes, well, I'm very pleased to be here to talk about what is happening in precision medicine, which I believe is going to change the cancer field completely and really maybe change all of medicine. So I'm a medical oncologist that treats patients with cancer. I spent many years at MD Anderson Cancer Center, built a new department there with early phase clinical trials, really became the largest department of its type, maybe in the world. And also spent many years at University of California, San Diego, building a precision medicine program. And really spent probably now about 15 years in this field, trying to bring the field from being just in the laboratory to bringing it to patients. And so that's a summary. I have a strong belief that this is going to make a huge difference in medicine, is already making a huge difference in medicine.
Okay, so let's start with the questions. Precision medicine is a buzzword these days. So let's start with that. Could you tell us what is precision medicine?
I'll be happy to do that. And sometimes people call it precision medicine, and sometimes people call it personalized medicine. But both terms really apply. And it's actually a really simple concept. We now have tools to understand what is wrong in each individual's tumor. So we didn't have tools like that 15 or 20 years ago, but we can now take a piece of tissue or even a blood test and know precisely, that's where the word precision comes from, what is driving that tumor. Now, why is it called personalized medicine? Because as it turns out, because each tumor is complicated and each tumor is unique, just like people are unique. You will never find two people that look exactly the same unless they're identical twins. You don't find tumors that are exactly the same. So because each tumor is complex and each tumor is unique, we need to individualize or personalize in order to be precise and get the exact right therapy. We need to individualize patient by patient. That is really different than anything that we've done in the past. But now we have new tools that makes this possible.
Thank you for that answer. So can you tell us about how precision medicine is used in colorectal cancer?
So I think it's used in a variety of ways, but I think the most important way is using next generation sequencing. And we can do next generation sequencing, which is looking at the DNA. The DNA is the code for really all of life. But there are parts of that code that have been broken or what we call mutated. And that's why you get a cancer, because the code is not working properly. So in colorectal cancer, we can look at the tissue and figure out what is wrong with the code. We can also do blood tests. They're called liquid biopsies. And it turns out that small pieces of DNA are shed from the tumor into the blood. And we now have these incredibly powerful techniques that were really unimaginable even a decade ago, where we can take a tube of blood and see what is wrong in the tumor because the DNA has been shed into the blood. So this is how we can apply precision medicine. Now, the problem for colorectal cancer and many other cancers is that the science isn't perfect yet. We've learned a lot about the broken pieces of code, the mutations, but we don't know everything about them yet. There are some mutations that may be very important that we don't know how to perfectly target. And when there are many mutations or many broken pieces of the code, we sometimes don't know which one is more important. But even so, we know enough that it can be extremely helpful to some patients.
Thank you for that answer. So this brings me to the next question, which is what is biomarker testing and how is that related to precision medicine and personalized medicine?
So that's a really important question. Biomarker is just another word that we use for any testing. It can be next generation sequencing or genomic testing. It can be protein testing. It can be testing for immune markers. It's biomarker. It's a biological marker. So we're testing for what is wrong in the tumor at some level. And then we're correlating that abnormality with a response to a drug, which may correct that abnormality.
So from what you said, should patients get biomarker testing to select the cancer treatments? How would biomarker, if I'm a patient, how would biomarker testing influence the course of my treatment?
So my opinion is that everybody should have biomarker testing. Now, I don't think that, let's say, all physicians necessarily agree with that at this point in time, although I strongly believe that within a short few years, every cancer patient will get biomarker, will get genomic testing at the time of diagnosis. So that's where I think that we're going. What I think is more controversial amongst physicians is what subsets of patients are appropriate for that right now. Now, again, I personally feel it's everybody, but I'm being honest by saying a lot of people aren't going to agree with that. But I think where people would agree is certainly for patients whose tumors have gotten worse after they've gotten classic therapy. That's a sort of no-brainer. They need biomarker testing. And then in colorectal cancer, testing for markers like KRAS, because that tells you that you may not respond well to EGFR antibodies. And then even more important is testing for markers like microsatellite instability, because even though that's a very small proportion of colorectal cancer, for those patients, the immunotherapy, which is the treatment with that biomarker, can be incredibly effective. So we can even, I'm not saying this happens to everybody, but you can even have patients that have failed to respond. The tumors have failed to respond to several therapies and they're not in good shape. And then if they're microsatellite unstable and you give them immunotherapy, in some cases, those tumors will go into long-term complete remission. So again, I'm not saying it's everybody, but you don't want to miss that chance.
So I think that you have kind of, explained the benefits of precision medicine. What are some of the challenges facing precision medicine, or are there limitations to using it?
I think there are several very important limitations. The first limitation is actually, what I alluded to before, the science. There are several genomic mutations that we often find in patients with colorectal cancer. We know they're important, but we don't know how to impact them. So I think that's a frustration. And then I think beyond that, is also that we have not trained physicians well in genomics. You know, it's a field that has really come on the scene extremely quickly. We use techniques now. I mentioned before liquid biopsies. We couldn't even imagine using them a decade ago. So the training, now we need physicians, oncologists that are highly trained in, let's say, genomics and immune markers. And that training, I don't think has been well established because the technology has moved forward at such a breathtaking pace.
With regards to colorectal cancer and precision medicine, are there some things that you want the listeners to keep in mind?
Yes, I think there are several really important things. So the first really important issue is that if you get comprehensive genomic profiling, almost certainly there will be abnormalities there that we don't know how to target. On the other hand, there will also be abnormalities where we do know how to target them, or they may permit navigation to a clinical trial. And I think being aware of what clinical trials are available is really incredibly important because there is so many new drugs that are coming out. And some of these drugs are so specific. They're not just for KRAS, but they're for an individual mutation in KRAS. And this is true for newly approved drugs. Like there's a newly approved drug for KRAS G12C as an example, but it's also true for drugs in clinical trials. They may just be targeting one specific mutation. So I think it's really important to have a deep knowledge and also access to what are the clinical trials out there? What are the drugs out there? That's not so easy, but it's a lot easier today than it was 20 years ago because of the miracles of the internet.
So how can patients find out if they are a candidate for precision medicine?
I think the best way is to speak to their physician and also to speak to other patients. You have this whole colon town, and what I find is it's amazing with patients who communicate with each other. Sometimes physicians get a little annoyed, but I'm amazed by patients. I think there are patients that come in and they know the entire literature. Like I think I know the literature, and boy, they know the literature. So I think it's really important to keep informed. And I think it's really also important to communicate with your physician. But there are different physicians that are at different stages of sort of adopting this. And I think that if you feel that maybe this is appropriate, but your physician's not interested, maybe you ask the opinion of a second physician or a physician that has published in the field. Now, maybe your first physician was right and it's perfectly not appropriate, but I think it's always worthwhile to ask a second opinion, and then you can feel more comfortable. Well, this isn't going to apply, or maybe there's another way that somebody with specific expertise might be able to help with.
I think that way you also covered, if somebody's interested in precision medicine, what can they do, right? You've covered that aspects too. And then the next question would be, beyond all of this, what is a good way to engage their care team? And, if they are not doing too much testing, what can patients do on their part?
I think you can bring information about the testing. And, I have patients come to me and say, what about this test? Sometimes I've never heard about the test. We had a new test that we do now routinely for looking at immune markers. It was a patient that first showed me that test. I wasn't aware. The company had just been born, basically, and I wasn't aware. But once I became aware of the testing through the patient, I thought, this is really interesting. We did hundreds of patients testing. So I think sharing that with the physician, sometimes patients bring in testing that I honestly don't believe is worthwhile, or worse, that, somebody's trying to make money, but I don't think it's worthwhile. But I also think I'm going to go back to the prior comment. If the care team doesn't seem interested, it's always worth getting a second opinion, because the second opinion might say, no, this testing isn't worth anything, or they may have a completely different opinion. And a lot of times you can figure out who to get a second opinion just by looking online and seeing who is publishing in that area, who is giving talks in that area. Or again, you have this wonderful patient advocacy community just by talking to other patients.
While you were answering this question, you mentioned that sometimes patients bring in tests that you might think are not good. So I know it's sort of a broad question, but are there, like, in ColonTown, for example, we hear about they take the tumor biopsies out and split them and put them in with a series of combinations of chemotherapies. I mean, can you tell us a little bit about what should people be kind of wary against?
So the first thing is that we really want to see testing that is clinical grade, what is called CLIA. First of all, legally, we're not supposed to make a decision based on testing that is only research grade. So we can use that testing to maybe do a study to see correlations. But if I'm going to make a decision on a patient, legally, it should be clinical grade testing, which is called CLIA. So I think that's the first thing really to look for. The second thing to look for is, again, publications. Are there publications that show that this works? Now, for some testing, like the type that you're alluding to, a lot of the publications are in cell lines or in animal models. They're not in people. I think that publications that are in people are the strongest, but I also think that we have to accept that there may be really good techniques that don't have information yet in people. So we shouldn't discard something just because those studies haven't been done, but we should consider them at a lower level than something that has been already shown to help in people.
Okay, thank you very much. I think that's the end of our questions, and thank you so much for spending the time with us.
Thank you, and it's my pleasure, and good luck.